I'm John McCullough from PositiveLight.com, and we're here today in Toronto at the annual research conference of the Ontario HIV Treatment Network. And we have just come out of a panel discussion that addressed the subject of when is the best time to start HIV treatment. And one of the panelists is with me today, Dr. Colin Kovacs. Colin is a HIV primary care physician working here in Toronto out of the Maple Leaf Medical Clinic, and is also a researcher at the University of Toronto's Department of Medicine. And Colin, research knowledge around HIV treatment is changing all the time, and we have seen over the last several years the guideline around when to start treatment, looking at CD4 cell count going from 200 to 350 and maybe now to 500 and beyond. So I'm just wondering, what is the science telling us about when is the best time to start HIV treatment?
Well, the problem with HIV is that it's been an evolutionary disease. And our ability to measure and also to determine what's important to measure has changed throughout the disease. So at the beginning of the epidemic, it was all about AIDS-related problems because we didn't know the disease was transpiring and infecting people. We didn't know people were going through immunodeficiency. It was only, back in the early 80s when people got AIDS-defining illnesses that became our focus as to this is what we have to prevent. I think as we become more sophisticated, and also because we have a greater armamentarium of medications, more and more of which are easier to take and with less toxicities and side effects, we truly have a better chronic, manageable armamentarium of drugs for people with HIV. And because of that, because we start stopping the viral replication and therefore stop the immunodeficiency, we've been able now to characterize what we used to think as clinical latency much better. And I think as we start to look at this as an infection, because the infection begins at the time of exposure, and the damage that's happening is not something that's related to what the person clinically presents at. So there is this period of what we used to call clinical latency, which is not virological latency, and it is not immunologic latency. The virus is there, the viremia is there, the damage to the immune system is ongoing. It may just take years for somebody to become clinically ill. With the drugs, and as we start using the drugs earlier and earlier, and people are actually now starting to live longer, and thankfully we've turned this, what used to be an ultimately fatal illness, to a chronic manageable disease. We're now having people live longer on the drugs and starting to see that maybe it's not just all about not getting AIDS-defining illnesses. Mm-hmm. We're now starting to awaken with these people who are suppressed on these drugs for longer periods of time, that there are other new problems that we never would have envisioned when we first came out with guidelines, start at this number or start at that number, etc. So it's a moving target based on what it is we're trying to achieve. I guess the problem is, and it's absolutely true, that we do not have evidence-based data, but we don't have it because we've never examined it. Mm-hmm. And because we don't have it, it doesn't mean that it won't exist if we studied it, or that it's not a bad idea to look at people as having a chronic infection, as we do with other chronic infections in humans, to say that probably it's best to stop that infection as early as possible for the individual. Now, there are community ramifications in terms of potentially making people less infectious, etc. But from an individual basis, to keep their immune system well and healthy, to prevent what we're starting to see now are these end organ damage from persistent viremia and persistent inflammation, both in the brain, the bones, the kidneys, some forms of cancer, and the lungs. I personally feel, although I have no clinical evidence because it hasn't really been studied in a large randomized trial, that this probably is no different than any other chronic infection.
Well, I think that many of us who've been around a long time will remember the time when we went on treatment, but the treatment was not efficacious enough, and so that we had tremendous side effects like lipoatrophy, lipodystrophy, neuropathy. How do we know that that isn't going to be the case with the current generation of drugs, which I admit are much less toxic, but they've only been with us for 10 years or less? So how do we know in 20 years' time these drugs won't provide the same?
It's an excellent question. We won't know. But I think that what we do have are not just a phase 3 randomized trial of 800 people from 70 different sites around the world. We now have at least 5, 8, 10 years of hundreds of thousands of people on these drugs, and finding surely some people there is a signal in terms of side effects and toxicities which actually pale in comparison to the first and the second generation of antiretrovirals. But there's no medicine that comes to the armamentarium of a physician that gets approval from Health Canada that will ever be able to say, without 20 years data, that in 20 years it won't cause a problem. So I think what we're starting to really truly see is this individual health benefit drug toxicity ratio is that it seems to be pointing that the drugs probably have less risk and stopping the infection, and that any individual probably has greater benefit long term. I guess the other issue about it is, as you appropriately said, we're starting people earlier and earlier and earlier. And if people are saying now 500, well, you've got to understand that most people, when they present at the time of the HIV diagnosis, are well below 500 in most geographies. My hope is with improved prevention and testing, we'll find people earlier. But even if you do find somebody with a CD4 count of 800 or 700, most people, 80% of the population, are intermediate progressors, meaning that if you do say, I'm going to defer to 500, it's really only a matter of a handful of years before somebody will actually be at 800 and get to this mark of 500. So we're really sort of myopically concerned about this issue around, do I start today or do I start in 3 years or 4 years? And that really, from my perspective, and I think when I chat to most patients, pales in consideration to being on the drugs for 30 or 40 years. So it's not a short-term, do I start here or start there at this particular number? I try with patients to give them their whole spectrum of what will happen with them in terms of their HIV infection over decades.
So let me ask you to propose a scenario to you as a HIV primary care physician. Supposing you have a young man who's 25 years old who has just been diagnosed by you with HIV and the infection is recent. What would you say to that young person?
Well, it's a very interesting question, because I think an acute seroconverter is potentially different. Somebody, what I mean by an acute seroconverter is somebody who's been infected for maybe less than 6 months or less than 3 months, may be absolutely different than somebody who's already 2 or 3 years into their infection. So if it's somebody who is chronically infected, who's 25, who's just discovered, I think in both scenarios, the decision to get on therapy is a very profound decision. It's a very meaningful and well thought out decision. It's not a decision that people should take lightly. It's a commitment that that person is making. But I think what some physicians do is they forget to empower patients, that they look at it from the negative aspects of, look, these pills, I'm sick, versus, look, these pills, I can do this and I can fight back at the virus. So I think some of it and lots of it is knowledge and empowering patients and telling them what we know, but most importantly, discussing what we think, because it's an evolutionary disease. And I think where we've been burned throughout the decades of this illness is that we stay in the camp of this, well, it has to be evidence-based before I will change. Mm-hmm. Because, to be honest, we don't call them anything but guidelines. This is not the 11th commandment.
Right.
These are guidelines. So this is the minimum level of what we would expect in terms of care. So this is a guideline for patients and for physicians to say, this is the minimum level of care or where the evidence is. But I try to deal with the maximum. I try to encourage patients to understand the voids and the gaps of our understanding, to also understand some of what the new research is suggesting in terms of the utility or lack thereof of CD4 count in terms of deciding therapy. But it doesn't really matter what the guidelines really truly are. Patients should only get started when they're ready to start.
Well, Dr. Colin Kovacs, that's a very helpful and enlightening discussion, and I'd like to thank you very much.
Well, thank you. It's a pleasure.
Thank you. And I'm John McCullough for the OHTN and PositiveLight.com.